All right, welcome everyone. We're ready for our trauma Jeopardy for the trauma junkies out there. We've got something for you tonight. This is what we're doing tonight, Trauma Jeopardy, and we're looking forward to having you with us. So as we go through here, I want to just tell you a couple things. First of all, my name is Dan Limmer. I'm the Chief Knowledge Officer at Limmer Education. And yeah, I've been out there, a cop, paramedic, educator, been out there for a long time. And my job here tonight is to give you some trauma preparation for the National Registry. And that's what we do here at Limmer Education. That's what I do. And I am really looking forward to this tonight. So I'm going to go up to my Jeopardy board here. We have a bunch of people here in the room tonight, and I encourage participation. I'll be looking at the chat here, so feel free to answer the questions, suggest something that you can add to this. And we have 5 topics tonight in the trauma categories: shock and trauma, chest and abdomen, musculoskeletal maladies, head and spine, and traumatic trivia. As we do this, we'll go through. Anybody can pick the next one as we go through. I'll pick the first one to get us started, and I think the best thing that we should do is, in fact, get started. We recognize that the National Registry is coming up. We're at May 7th. People are finishing their classes and going through, and this Jeopardy is a great way for us to give you some information. 2 weeks ago, we did trauma. In 2 weeks, we're going to do the Tournament of Champions and do some really significant, challenging trivia questions for you as we have throughout this. So I'm going to go through and I'm going to start choosing one of these, but please, in the live chat, feel free to put in your answers and to put in any requests you have. Now, all right, trauma. I'm going to go all the way over to traumatic trivia for 100. And here we go. The pulse pressure should be at least this percentage of the systolic blood pressure. The pulse pressure should be at least this percentage of the systolic blood pressure. In the chat, put your answer in. We've talked about, what does a narrow pulse pressure mean? What's normal? What's abnormal? What do you think? What's the answer? This is important. This is important for your patients, and it's important for the National Registry as well. Does anyone have an answer to this? I'm going to let this go in a second because there are times the National Registry doesn't give you all the information you want. They give you little pieces of information. And in this, one of those is the pulse pressure. As we go through, all right, we're going to go through and get the answer. The pulse pressure should be at least 25% of the systolic blood pressure. So if the systolic blood pressure is 100, we have 25%, we should have a 25-point difference between the systolic and the diastolic. Now the pulse pressure is the diastolic subtracted from the systolic. 120 over 80, we subtract 80 from 120, we get 40. It's a beautiful pulse pressure. When we get to 118, when we get to 108, for example, over 88, then we've got a little bit of a different situation there. All right, so 25% of the systolic is the minimum pulse pressure that we should have. All right, I'm going to look for a few more answers here in this live chat. I don't see anything yet as we go. I'm going to come over to shock and trauma. Shock and trauma is a very big part of what we do. And let's hit that for 100. This type of shock results from loss of vascular tone. This type of shock results from loss of vascular tone. All right, we have some great answers here. We had some good answers for the last one. They didn't pop up on my screen. I was a little delayed. But yeah, 25% is there. And we also have some really great names here that are coming through. Windswept Homestead. Hello. All right, the type of shock results from loss of vascular tone. Now, Hughes, Sterling, guns are fun. Yeah, that's one of the possibilities, but that's a narrow part of that. Remember, there are 4 functional descriptions of shock. And from that, each one of those 4 functional descriptions can take us a little bit further. So this type of shock results from a loss of vascular tone, and that is distributive shock. Now that can go from a number of things. We see that in anaphylaxis, we see that in sepsis, and as several people have mentioned here, yes, we see it neurogenic. I think it's important to look at shock. Now, you can look at shock as shrimp can or RN champs. There's all those different types of shock, but there are 4 basic descriptions of shock, which all of the other ones fall into: distributive, hypovolemic, obstructive, and cardiogenic. I think it's important to remember those as we go. But we are going here, we're moving along, and remember that you can request at any point, have me jump in and pick a different one. I'm going to do musculoskeletal maladies for 100. Now, remember, the 100s are relatively easy. The 500s are much more challenging. The traction splint is used on this bone and this bone only. What is that bone we use the traction splint on? We're warming up here. We're making it relatively easy. We're giving you an easy 100 choice here. There we go, YG. CJ is back. And yeah, there's a lot of discussion about the traction splint right now. And there we go. Eric and Windswept Homestead. That's a great name, just for the record. The traction splint is used on the femur. Now, it's only used generally on the mid-shaft femur. One of the problems with the traction splint is that it's relatively rare. Now, actually, I have a comment just came in about closed femur. You can actually use this on an open femur fracture, because ultimately, even if you pull the bone back in, it's going to have to be debrided and things as we go. There's really not a lot of concurrence on, it's only open or, it's only closed or open. That in theory, we could use this on an open femur fracture. The problem that I have with this is that it's very rare that we have one isolated mid-shaft femur fracture without any damage to the knee or to the hip or to other things. And I think that's one of the issues here. Every time we do these Jeopardies, we don't just give answers, we have important discussions about why these things are important. And it's my belief that the nature of the traction splint is that it's rarely used because isolated femur fractures are, in fact, relatively rare. All right, as we go through, I'm going to just start doing these, checking off these 100s. I think it's important that we talk about what we do when we have a dispute about something. More than one person has had a closed femur fracture. The nature of the traction splint is that it's a bleeding control device. It pulls the bones in line. It makes that space inside the leg smaller. It reduces bleeding. And that there is some literature out there that says it doesn't matter if it's open or closed, that you could still use a traction splint. But I think what's really important is that when we do this, we recognize the parts of the traction splint and how and why we do it, and that the bleeding control and the other things that are important, regardless of whether it's open or closed, in fact, make a difference. All right, I'm going to use chest and abdomen. JVD, hypotension, and absent lung sounds point to this critical chest injury. JVD, hypotension, and absent lung sounds point to this critical chest injury. What specific kind of pneumothorax are we talking about here? There we go, Eric. Yeah, we're talking. All right, we got a couple answers here that I like. We're looking at a tension pneumothorax. Now, let's teach about this for a second. This is what we do to get you ready for the National Registry. JVD, hypotension, and absent lung sounds on one side of the chest at least point to this critical chest injury. That's a tension pneumothorax. Now, tension pneumothorax, we look at and we say, oh, the lung is collapsed. There's hypoxia. But the truth is that a tension pneumothorax is more of a circulatory emergency than it is a pulmonary emergency. Let's say that I had a problem with my lung and I had one lung surgically removed. I can still function on one lung, right? It's the circulation. It's those low pressure vessels coming in from my head. I'm draining from my head, trying to get back to the right side of my heart, and my neck veins pop out. And then as I'm trying to get blood from my lower extremities and my belly back into the heart, I'm getting that kinked because of that pressure from the tension pneumothorax. It's primarily a circulatory issue with pulmonary complications. And that, in fact, is a tension pneumothorax. So I had a request for head and spine for 200. We're jumping ahead a little bit here. Well, let's do that. Here we go. Cushing's Triad includes hypertension, bradycardia, and this additional sign. Cushing's Triad includes hypertension, bradycardia, and this additional sign. I'm looking at my notes here. I'm looking at my live chat for y'all to come through here. What are the three parts of Cushing's Triad? All right, CJ, that's exactly what I was going to say. There are a lot of different types of breathing. There was actually a paper out there that had people looking at different breathing patterns, and even resident physicians couldn't identify one from the other. But there's one thing, Amanda, I'm in agreement with you as well. I think that what we have here is Cushing's Triad is hypertension. Why? Because we have pressure inside the skull. We've got to feed that brain. So we increase the blood pressure to feed that brain. Bradycardia, because the baroreceptors say, holy cow, the pressure's getting so high. We got to do something about this. So we bring the pulse down with the parasympathetic nervous system. But the other sign is irregular respirations. Now, yes, it can be chain stokes or others. The truth is, it doesn't necessarily matter. When we start to squish the medulla down, we start to get those irregular respirations. When we start to get herniation, our brainstem starts to get squished down throughout foramen magnum. Irregular respirations are the answer. Chain stokes, of course, is one of those, but identifying those. Remember, chain stokes is a crescendo, decrescendo pattern. We build up and then we come down, and we build up and then we come down. But I think irregular respirations are totally fair game when it comes to this. All right, I've got head and spine for 100 just sitting there by itself. I'm going to use that right now. Let's see what it says. Dermatome charts, you've got them in your textbook. I think there's a few things you should know. You don't have to memorize them all in EMS, but this dermatome innervates the chest at the nipple level. This dermatome innervates the chest at the nipple level. Which one is that? I'm looking for answers right now. There are two in the thoracic spine that I think are relevant. Do we know what those are? Very silent out there. All right, the people are, listen, Jamin, you're taking a guess. I like that. The nipple level, here we go. All right, YG is getting closer. It's T4. The dermatome that innervates the chest at the nipple level is T4. The umbilicus, the belly button, is T2. T10. Those are two good landmarks that you should know from thoracic dermatomes. T4 is the nipple level, T10 is the belly button, or umbilicus. All right, so I'm going on from this. We're hopefully learning lots of different trauma things as we go here. I'm feeling the trivia, although you can always put another answer in here. Ask me to do something else. We're doing traumatic trivia for 200. Impaled objects are usually left in place unless they are here. Impaled objects are usually left in place unless we find them here. Where would that be? I think you know this one. Wow, we got lots of stuff here. Interestingly, yeah, if we have something, some giant piece of rebar that's in the chest that says we can't do CPR, I suppose that's going to be an issue. But the most common thing that we see here, and thanks to everyone for participating, that impaled objects are usually left in place unless they are here, that is the cheek. I'm talking about the cheek here in the face, not the other cheek you might be thinking of. Why is that? Well, there's two reasons. One is that blood may affect the airway. We have something that goes through the cheek into that mouth and the airway. But one of the things about the cheek we have that we don't have in most other places of the body, we can feel both sides of that object. So in theory, I could take my fingers, put them in the mouth alongside that, and if I were to take that out, I could stop the bleeding and know the way it came out. The general reason we don't take out impaled objects is we don't know how they went in, and pulling them out may cause more damage. The cheek is the general exception we have for those two reasons. One is that we can actually see both sides of where that impaled object is, and two, and perhaps most importantly, it could affect the airway. And many of you said that. All right, I'm going to go through. Please put in more requests of this. Now, if you have something that's in the way of compressions, one of the things we do is we look at these and we say, oh yeah, if there's something in the way of compressions, like, okay, if I've got a giant piece of steel that's going through someone's chest and coming out the other side and I can't do compressions, right, if the patient's not talking to you, maybe we don't have a ton of chance to begin with. But the truth is that occasionally we do get very challenging impaled objects. In the cheek, yes, that's one that we can take out, and CPR is in fact another one. But if we get one that's in the way of CPR, that's a challenge. All right, I've got a request from YG for traumatic trivia for 400. We're going big, we're going down. Here it is. A patient has cirrhosis of the liver and begins to vomit large quantities of blood. What is the most likely cause? A patient has cirrhosis of the liver and begins to vomit large quantities of blood. Oh, if EMS is a glamour thing. What is the most likely cause? Margie is back. It's very good to see you. Yes, that is most likely what it is. I agree. Jim is back. Esophageal is exactly the way, the pressure, the liver, that all that pressure backs up and it goes into the vessels in the esophagus, and that creates ruptured esophageal varices. It's a horrible, vomiting, bloody, sometimes death. I've seen this several times in my time in EMS. It's a horrible resuscitation. People aren't often prepared for what's going to happen. But in that, those vessels, ruptured esophageal varices in the esophagus, these varices are distended blood vessels because of increased pressure in portal circulation, the portal in the liver. When that happens and they get bigger and bigger, they will eventually rupture. Now, they generally rupture, go down into the stomach, but in the stomach, blood is an irritant, so we vomit, and that vomiting blood is a horrible situation. Now that I've cheered you all up here a little bit, I have several requests here, and I like that. All right, so we did shock. Next one is shock and trauma for 200. Here we go. This type of traumatic shock presents with JVD. This type of traumatic shock presents with JVD. Hello, Starla. Margie, I'm going to keep my fingers crossed for you. Let me know how you do. This type of traumatic shock, you know, these 4 functional descriptions I think are so important in pathophysiology. CJ, LD, Eric, YG. Yeah, no, this is the answer. It's obstructive shock. Where do we see that in trauma? We see that in tension pneumothorax, and we see that in cardiac tamponade. Now, obstructive shock medically can also be caused by a pulmonary embolus. You might not get the JVD from that, but remember, what's the function? We need to know why. Why do the neck veins stand out? Because all the blood that gets pumped up to the brain tries to get back and it can't. It pumps up those neck veins, and that's really, really important. All right, so we're going up. I've got head and spine for 500. Are you ready for 500? Who requested that? Guns are fun. Here you go. Blows to the temporal area of the skull may damage the middle meningeal artery and cause this type of intracranial bleed. Now, you wanted the 500. Here you are. Blows to the temporal area of the skull may damage the middle meningeal artery and cause this type of intracranial bleed. Look at you. You guys are doing awesome with this. Jammin and Margie have got this. So anybody else wants to jump in? I have a couple different bleed questions here, so I want to give all my answers to other ones. But yeah, all of you that are saying that epidural, yeah, you know, the temporal part of the skull is one of the weakest, and that vessel right there can tend to give us those epidural bleeds. Now, the concept of the epidural bleeds say that there's a lucid interval where you go out, then you wake up, and then you go out again, and that's the big problem. That doesn't happen, you know, all the time, but it's important to know where the head trauma is and what's going on, and that epidural does happen not exclusively, but very commonly from those temporal lobe injuries. It's important that we know these things. I've actually seen a couple of those, and they can be devastating. They really, really can. All right, so we're going to go into chest and abdomen for 200 by request here. Oh, this type of abdominal pain is diffuse and difficult to pinpoint. This type, here's my Jeopardy voice, this type of abdominal pain is diffuse and difficult to pinpoint. What is that called? You know, I learn a lot from my students. My students have taught me a way to remember this, and I'll share that with you as well. Look at you guys are off. Yeah, exactly. All right, I'm just going to jump to this. We've got this really well here. Visceral pain. You know, my students say visceral pain is vague. Organs are not particularly well innervated. So because of that, if my appendix starts to give me trouble, it doesn't report right there at the appendix. It goes back to my belly button, about T10. And why is that? Because that's where it reports back to the spine. And the brain says, when you report to the spine, I feel it at the belly button, so that's what I'm going to say it hurts. But the nature of it is that it really is lower, and visceral pain is vague pain. It's not until the appendix ruptures or gets really big and knocks on that peritoneum that we can say, oh yeah, right lower quadrant is where it hurts. That we don't have, those of you that have heard me teach before say, if I put my hand on the table and I whack it with a hammer, I know exactly where it hurts because of all those nerve endings. But my organs don't have those. So it's much more vague. That visceral pain, in fact, makes a difference. All right, I'm going to go to musculoskeletal maladies. We're going to clear up this 200 level, but requests are always welcome. Musculoskeletal maladies for 200. Ooh, this distal pulse point is found on the dorsal surface of the foot. This distal pulse point is found on the dorsal surface of the foot. Now, I will admit, since this was only a 200 level question, by putting dorsal surface, I did give you a little bit of a clue, and many of you have gone on to that clue and have done well with that. The dorsal, or the top of the foot, is where we find that dorsalis pedis pulse. Now, on the medial side, we have the posterior tibial pulse on that big old ankle bone in the middle. But those are the two places we look for. But the dorsal surface of the foot is the dorsalis pedis. Now, the National Registry doesn't always give you things that are this linked, but read the question. If you have the dorsal surface, pick up the dorsalis pedis. I would hope that you would be able to do that. All right, we want to go. All right, we're still going for the big. Yeah, that is the same as the pedal pulse. It's one of the distal pulses. The pedal pulse, pedal meaning foot. The top of the foot is the dorsalis pedis, but again, on the medial side of the ankle is the posterior tibial pulse. All right, so I've got a request: shock and trauma for 500. People are in the go big and go home mode here. Here we go. The trauma triad of death. All right, let me say that. The trauma triad of death. Trauma triad of death. I want to make this, you have the influence there. Includes acidosis, coagulopathies, and this preventable factor. The trauma triad of death includes acidosis, coagulopathies, blood clotting problems, and this preventable factor. Amanda, good job. Gomez, very good. And this, why would we have a preventable factor that we wouldn't take care of, right? Give people a little more time to answer. When it comes to trauma and shock, I think we've come to realize that what we can do in EMS, whether it be BLS or ALS, is somewhat limited. But sometimes the simplest things are, in fact, the most important. And in fact, hypothermia. We forget that the body temperature is 98.6. It might be 80 degrees out. And it's been, well, it was 50 overnight. I still have my job shirt on. I'm in the ambulance. It's hot. We want to turn the AC on and we do this. But the fact is the body temperature is 98.6. Hypothermia worsens shock. There is just no way around that. Acidosis, blood clotting problems. But one of the things that brings us in there is hypothermia. We don't want to bring our patients to bake 350. We don't want to put them, where they're really, really warm. What do we want to do? We want to maintain their temperature. Sometimes the simplest things make the biggest difference, but we want to start IVs. We want to do all these things, but simple sometimes is just so important and so good. All right, making sure I'm getting all of these. All right, I'm going to go chest and abdomen for 300. Feel free to put your questions in, your requests as we go. Oh no, Beck's Triad. Beck's Triad consists of hypotension, muffled heart sounds, and this finding. Beck's Triad consists of hypotension, muffled heart sounds, and this finding. Look at y'all go. All right, this may not have been a 300 level. Maybe it was a 100 level, but look at y'all get, yeah. Now, let's talk about Beck's Triad. Beck's Triad doesn't show up in everyone. What's this? What does it mean to us? Well, first of all, we can have our Echo Core, really cool electronic stethoscope, and be listening to heart tones. But while we're careening down the street in a diesel ambulance with all the other noise we have, will we always hear muffled heart sounds? Yeah, I'm not sure. But hypotension and JVD, that's significant. And if I can figure out my lung sounds, I might be able to determine if it's time to call for ALS, or if you're ALS, to be able to do a chest decompression, right? So to do this, Beck's Triad is all about cardiac tamponade. All right. So when we do these things, now we talk about all of these things, but some people say 40 to 60% of people with tamponade may not have all the components of Beck's Triad. So I think it's really important that we look, when we say JVD, yeah, that's really important. If we look at somebody who's a train wreck and you wonder why they're not bleeding out, but you see JVD, we think obstructive shock, and something is in fact going on in that chest. All right, as we go through, lots of great answers there. I'm going over to traumatic trivia. You know what? I'm going to 500. Let's live on the edge. Traumatic trivia for 500. Oh, loss of 1,750 mLs of blood, or about 35% of the blood volume, results in this stage of blood loss. Now, I'm not necessarily big on numbers and memorizing things, but if we're going for 500, we've got to have a big one here. At what stage of blood loss? Now, I'll tell you, it's basically 1 through 4. All right. And with this, we're going to be pretty clearly out of compensated shock into decompensated shock. We've left a certain amount of blood on the ground here. So if we have stage 1, stage 2, stage 3, and stage 4, what do we have here? And the only reason I would ask you this is because we are on the 500 level of traumatic trivia. And the truth is that we are at stage 3. Stage 3 is less than 2 liters and less than 40%. Once we hit 2 liters and 40%, we are in stage 4. Yeah, that's pretty close to irreversible as we go. I chose one here. 1,500 to 2,000 is stage 3, 30 to 40% of blood loss. Holy cow, we are just circling the drain as we go here. So stage 3, how would we get to stage 4? If we have the misfortune of doing that, we would have more than 2 liters and more than 40% of blood, and that does get us to that irreversible stage of blood loss. All right, somebody wants to go for 500 some more, in for chest and abdomen. I can do that. Here we go, chest and abdomen. No, it happens. This is how we learn. And remember, that was a 500 level. I put that in there. Remember that we have, stage 1 of blood loss, right? What's stage 1? Well, we can give blood. We can give up to 750 mLs, or, and we can be okay. Stage 2, we're getting up there a little bit, right? We're getting up to 1,500 mLs, twice the amount of a blood donation. We can probably still compensate, but we're getting close. Stage 3, what's that? That 1,500 mLs to 2,000 mLs, we're getting, 30 to 40% of our blood loss. That's really bad. Stage 4, pull out the bugle. That's why it's important to know those things. That's why we're doing those. All right, so we had a request for chest and abdomen for 500. Here we go. This condition results from compression of the chest cavity. It causes edema and discoloration of the face and neck. This condition results from compression of the chest cavity. It causes edema and discoloration of the face and neck. Stand by.
Hi, good evening.
Hi,
Do you need towel?
No, I'm good.
Okay.
Thank you. I'm back. I'm at a hotel in New Orleans doing this. And I know, poor me. And someone just came. All right, CJ has got the closest here. We got the asphyxia. I know. Imagine I'm trying to do this and somebody rings the doorbell and it's the maid wants to give me towels. All right, this condition results from compression of the chest cavity. It causes edema and discoloration of the face and neck. Yeah, when people say crush syndrome, we have asphyxia. What we have here is called traumatic asphyxia. What we see is that someone has significant pressure to the chest. We see this in injuries where I've seen it in people that have been run over. A guy was run over by a tractor and it ended up sitting on his chest. Well, it pushes that down on the chest. Therefore, it pushes the blood up to the face. So the neck and the face are often very red. You may find petechial hemorrhages of the eye and the face, little pinpoint blood types things. That's called traumatic asphyxia. A sudden massive compression of the chest or a consistent compression of the chest that pushes blood back up into the face and that vasculature is called traumatic asphyxia. All right, there we go. So I'm going to go through. All right, you want to just keep doing 500s? I'm in for 500 if you're in for 500. Let's do 500 in musculoskeletal maladies. Here we go. Your patient has fractured their Olecranon process. What would you be splinting? What part of the body is the Olecranon process? I'm pretty sure I fractured mine in February. Took about 6 or 8 weeks so I could move this part of my body well again or put weight on it. Your patient has fractured their Olecranon process. What would you be splinting? Guns are fun. Listen, you don't have to be in an EMT class. I'm glad you're here. Margie, and you've got... How do you all know this? That is the correct answer. It's the elbow. And when you fracture the Olecranon process, many times you land directly on the elbow. It's that very posterior, it's a very proximal part of the radius that sometimes gets cracked when someone falls and lands directly on their elbow. The Olecranon process is the elbow. All right, I thought I'd get you with that one. I did not get you with that one, and therefore I am impressed. All right, let's start cleaning these up. Traumatic trivia for 300 is going to wipe out that category. It is, all right, Windswept Homestead, let me tell you something. It is not funny when you do it. That whole funny bone thing, not so much. Trust me. All right, here we go. Ooh, heart rate divided by the systolic blood pressure is the formula for what shock-related measure? Heart rate divided by the systolic blood pressure is the formula for what shock-related measure? I was at a training meeting for an EMS organization, and the medical director was actually part of a study that did this. And yeah, this is totally different than the things that you all are saying. The mean arterial pressure, the pulse pressure. No, this is amazing and it's simple. And I don't know why we don't do this more. I found this fascinating. It's out there. There's research on it. It is called The shock index. The heart rate divided by the systolic blood pressure is the formula for what measure? It's the shock index. So if it's greater than 1, you're generally okay. Now think about this. Heart rate. Let's say I'm doing really well. My heart rate's 70. My blood pressure is 120 over 80. So 70 divided by 120, it's much less than 1. But think about shock. Now my heart rate's 120, but my systolic blood pressure is 90. What happens? Well, I'm 1.3 then, and the shock index is bad. I would encourage you. Shocking. All right, now I'll do the jokes here, okay, as we do this. Very good, Margie. The nature of this, though, think about this. I want you to Google this, the shock index, right? If somebody's tachycardic at 100, but their blood pressure is 90, it's less than 1. And it's just a very simple and amazing thing. And these are the things you learn over time. Just stay, go to the trainings, go to anything that you have, grand rounds or things the hospital puts on where you get to listen to really smart people talk about shock and trauma and medical emergencies. And there's always so much to learn. I know that I did. All right, I'm going over to the left side, shock and trauma for 300. Here we go. Oh, this type of tourniquet is used in the axilla and the groin. This type of tourniquet is used for the axilla and the groin. Yeah. So much of what we do, we learn from the military. A lot of things are tried in the military. I think a lot of people are putting incorrect answers here. And we've learned so much from what we've lost in battle and who we've saved in battle, quite frankly. And the answer for this type of tourniquet is used in the axilla and the groin. The truth is that it's very difficult for us to control bleeding there, but junctional tourniquets make a difference. So I'll also say that there's a recent position paper out. The military does tourniquets high and tight, and that's because they're in battle and they've got heavier clothes on and a lot of different things. There's a position paper out about tourniquets from the College of Surgeons, and it says that in civilian EMS, we don't have to do high and tight, that if we can expose the patient, we're not in battle, we're not under fire, we're not in those austere situations where we may actually go that normal 2 or 3 inches above the bleeding wound and put a tourniquet on, and that's okay. They do work, and it can be done that way. We're not necessarily in battle. So if we're out in the middle of the street and we see somebody's got bleeding from an extremity and we have our scissors, we can open up take the clothes off that extremity and look at it and say, okay, I'm going to put the tourniquet here because we have that ability to do so. So there's a lot of misinformation about tourniquets. We like to follow the military. The military does high and tight. We don't always have to do that. So there's a position paper out about that. I believe that's also very important. All right, head and spine for 400. I'm going purely by request when I can here. Ooh. These 6 vertebrae innervate much of the body's sympathetic response. These 6 vertebrae innervate much of the body's sympathetic response. Now we're getting harder. We've wiped out the 500s, but we still need to know important physiology and pathophysiology. Now, we know the sympathetic nervous system does several things. It speeds up the heart. It dilates bronchioles. It constricts our blood vessels. I personally think this, I teach this in my EMT classes, but there's a lot of people in AEMT and paramedic that may not necessarily know this. So I'm not saying this is the only place, but this is a very big place where this happens. There's a lot of people saying cervical. Let me show you the answer here. It's T1, to T6. Now, let me tell you a couple things. I'm going to give you, now if you're writing stuff down, if you want to pause this, if you're listening to this later, pause this down and write this down. The parasympathetic nervous system, not sympathetic, parasympathetic is craniosacral. Right? We have the vagus nerve, what feed and breed, right down in the sacral region. The sympathetic is thoracolumbar, especially the first 6 vertebrae of the thoracic spine. So if I damage that area of my spine, that's where I'm going to see the effects of that spinal shock. Below that level, I'm going to see skin that's not cool, pale, and moist. It might be red. Why is that? Because my sympathetic nervous system can no longer do that. So it's important to remember the parasympathetic, craniosacral, sympathetic, thoracolumbar, but most importantly, a lot of the juice we get from that sympathetic nervous system is T1 through T6. And that's why that's really important. I mean, think about that. T1 through T6. We know T4 is the nipple level for the dermatomes, so we're going down, right, almost to the diaphragm. So in doing that, we're saying, okay, this is the part that does that. Now, there's a few other things. I'll give you other, I've said this in other sessions I've done, but for the diaphragm and breathing, C3, 4, and 5 keep the diaphragm alive. Right, let's sing it together. C3, 4, and 5 keep the diaphragm alive. The brachial plexus down to the phrenic nerve gets down to our diaphragm. That affects our breathing. That's cervical. Now you say to yourself, well, if that's cervical, you know, why is the... Okay, but that's where our body just comes together and does what it does. So Jamin says, so if neurogenic shock or spinal shock, we only see warm, dry skin, T1 and below. Near the, let's say that there's T1 or T3 or T5 from that level and below. And again, that's that sympathetic nervous system that responds in there. It depends on the level, T1, 2, 3, 4, 5, 6, depending on what level that it's at. And remember that not all spinal injuries are transections of the spine. And that's sometimes where we often have mistakes as well. All right, I'm going to 300s for head and spine to put this up there. This class of medication, often prescribed for AFib, complicates head injuries. This class of medication, often prescribed for AFib, complicates head injuries. Checking to see what y'all think this is. All right, Margie, if I'm a betting person, I'm betting on good results, but the National Registry is going to tell you when they're going to tell you. Yeah, CJ, I agree. Give it a couple more seconds here. All right, the answer for this one is in fact blood thinning medications. There are certain medications like apexaban and the old Coumadin, warfarin, certain things. If someone falls and hits their head and they're on blood thinners, there's a certain concern that that blood, especially when we have a venous bleed, that it could go slowly over a period of time unnoticed and then be a crisis. In the old days, anybody that was on any of the blood thinning medications, whether it be the old time Coumadin, warfarin, or some of the other medications, Eliquis and others that are out there, that they had to go to the hospital. I mean, I don't know how many times I've taken people from assisted living facilities that have fallen because they hit their head and they have to send them out. And ERs largely do CAT scans. They don't always do CAT scans. But if somebody hits their head and they're on a blood thinning medication, do we have to be careful? Oh, absolutely. Yes, we do. All right, I'm going to take a look and see what we have here. I have a request I didn't get to. Head and spine for 400. Okay, we took care of that. Let's go to 300. I have one more 300 musculoskeletal. Let's do that. Ooh, this type of fracture is incomplete. and seen in children. This type of fracture is incomplete and seen in children. Yeah, that's the one. Alicia, I didn't see you come in. Welcome. Yeah, the concept of the Greenstick fracture. I have to tell you, one of the things that was told to me in my online live national review sessions that I do weekly through emtreview.com and paramedicreview.com, one of the things I sometimes will have flashbacks to what instructors have told me. And one of them was that kids are bendy. That kids can have big trauma inside without a lot of damage outside. Now, if I got hit with a big stick in my chest, it'd break some ribs and then you'd have a pulmonary contusion. But in kids, what happens? You boom, you hit those ribs, the ribs go in, damages the lungs, but the ribs pop back out. And the same thing with bones. We may not have a snap, boom, break fracture. I mean, you can have that, but the Greenstick fracture is incomplete and it's seen in kids. All right, I've got 3 more left. Let's just go left to right. Shock and trauma for 400. At the end of this, we're going to do a couple of National Registry style questions just to get us in some review mode. We've covered a lot of trauma material here, and you've all done so well tonight. I'm very happy to be here and happy to be with such a group of smart people. For those of you that watch this later online, there's a lot of good material here, and I'm glad that you're here. The transition from compensated to decompensated shock occurs when this happens. The transition from compensated to decompensated shock occurs when this happens. Yeah, we're getting some answers there right off the bat. And yeah, that's really it. It's pretty simple. The body has the ability to compensate for shock. And what does that compensation mean? That compensation means that we keep our perfusion going. We keep our blood pressure up to do that perfusion. But when the blood pressure drops, the blood pressure drops, we've transitioned from compensated to decompensated shock in the purest sense of the word. All right, chest and abdomen for 400 as we start to wind down. Oh, I hate when this happens. Exposure of abdominal organs as a result of trauma is known as this. Yeah. When we do these pictures for textbooks, we go to the butcher, we get some sausage, and then we mix up some Caro syrup and coffee grounds and red food coloring. And we make these things. When you see them in your book, it's hard to find real eviscerations, although Ed Dickinson, the medical editor for the emergency care book, actually has a photo of a real evisceration that's relatively rare. And we make these big eviscerations like your guts are all hanging out. A lot of times it's relatively small, just a single loop. And yes, that is in fact an evisceration. There are only a few things that we put occlusive dressings on: eviscerations, open neck wounds to keep air from going in, and open chest wounds. And the last one, musculoskeletal maladies for 400. Here we go. This pre-splinting action, when performed on a long bone fracture, may reduce pain and limit bleeding. So it's before splinting. This pre-splinting action, when performed on a long bone fracture, may reduce pain and limit bleeding. CJ's got the direction that I was looking for here. A lot of people say, oh, you don't do this, but yeah, as a matter of fact, you do. The concept of holding traction, stabilization, different things, the concept of doing this freaks you out just thinking about it. I mean, it really freaks you out thinking about it. But the answer to this, in fact, is aligning the extremity to anatomic position, straightening that extremity. And there's two reasons why. Now, I'm not saying it doesn't hurt when you straighten it. It's not Funville, let me tell you. However, if you can take an angulated extremity and you can move it back into anatomic position, two things happen. One is those bone ends aren't all contorted and the muscles aren't pulling things in a horrible angle. And the other thing that happens is once we get them back in line, the amount of space that's available for us to bleed in, sometimes it reduces bleeding. So straightening long bones, we generally try to do that if we can, if in fact, when we do this, that there's not too much pain. There's going to be pain, that there's no resistance. We try and get those bones, long bones, not joints, back into anatomic position. Straightening those things will actually reduce pain once that's over generally and reduce the amount of bleeding. And that gets us to the end of this Jeopardy game, but we have a couple National Registry style questions we want to do just to take up these last couple minutes of our session. And the first one is on your screen right now. Take a moment to look at this. Remember that you have at least a minute for National Registry questions. The registry says it takes only about 30, 32 seconds to answer a question most of the time. So you have the chance to look at these. A 34-year-old patient was involved in a motor vehicle collision. They're oriented and present with the following vital signs. Respirations are 20, pulse is 92 and regular, 102 on 84. Which of the patient's vital signs would most reliably indicate criticality? All right, they're oriented, and that's good, right? Respirations at 20. All right, they're in a motor vehicle crash. Pulse at 92. Holy cow, I mean, you get in a crash, you get a little worked up. Blood pressure, 102 on 84. I'm looking at that. Are you guys seeing what I'm seeing? Yes, you are seeing it. I can't fool you guys for nothing. Maybe you've been listening to me for long enough to recognize these things. What is the pulse pressure on that? So 84 is 16, add 2 onto that is 18. That pulse pressure should be 25 or 26, but it's only 18, that pulse pressure, with a little bit of a increased pulse. That pulse pressure, that's the blood pressure, that's the issue. The pulse pressure is narrow. All of you who said D did the exact right answer. The National Registry never hits you over the head with the right answer. They make you read a question and have to think. So many people fight the registry and say the questions are evil and blah, blah, blah. They're not like the street. But you know what? Sometimes there's a subtlety that gives you, and I've been there on the street. Sometimes there's a subtlety that says, I got a bad feeling about this. This patient is just doesn't seem right. We're going to go to the trauma center just in case. Maybe it's this blood pressure. But that blood pressure does, in fact, make a difference. It's a narrow pulse pressure. Very well done. And here is one more question. This is the you should question. Everything ultimately tests your judgment. When you go out there, listen, I write an EMT book, and we try and do the EMT book really, really well. I mean, boy, do we try. But there's always going to be different situations you get. So this 66-year-old woman was involved in a moderate speed crash. She's alert and she complains of difficulty breathing, air quotes here, due to her COPD. She has tenderness in her neck. So to restrict motion of her spine, you attempt to lie her flat, but she becomes agitated, says, I can't breathe. You should next. Well, restrict motion of her spine, you try and lay them flat, but now she can't breathe. She has COPD. What do you, you guys are so far ahead of me here. Yeah, sit the patient up. We don't have to ventilate for her. We don't have to restrain her. you will lay down and you will like it. I'm going to restrain you, right? No. Administer high concentration oxygen. No, let's start by doing the simplest thing first, right? Sit the patient up where she can breathe. You guys did awesome here tonight. You know, the answer here is to sit them up. Now, the American College of Surgeons and all the surgeons groups say in the spinal motion restriction papers, we try and lay them flat. But if they can't breathe, we sit them up a little bit. Or if the woman is in their third trimester of pregnancy and they're lying flat and they have supine hypotensive syndrome, we can change that a little bit. We've gotten rid of the backboards. Now we have the ability to do good for patients. Let's in fact do good for patients, right? That is in fact what we do. So, all right, that's me there. My emtreview.com. We also have paramedic review stuff there. We do these questions weekly. We spend time teaching and going over questions and doing these. It's a site where I loved. I think hopefully you can tell by tonight. I love to teach. I love to be together and to be able to help you learn and get ready for the National Registry. emtreview.com. We have paramedic material there as well. We have, if you're looking for more, if you're saying, I don't know how to study, I don't know what to do, I'm trying to get ready for the National Registry and I'm struggling, this is the place for you. We have guided study. We have all kinds of tests. You can take a few questions and watch me explain them. You can do diagnostic tests. And then we have these live sessions with me every week. And I would love, love, love to have you there. So emtreview.com is a brand new site. We have a beautiful new design. There are a lot of resources there for you. And I would love to have you come by and take a look at that. emtreview.com. We have EMT and paramedic stuff there as well. I hope you had as good a time as I had in doing this tonight. I make up these Jeopardies and I try and make them challenging as we go on. I do some nooks and crannies. I do some important stuff. That pathophysiology is so important, and I'm really thrilled. If you were here while doing this live, I'm very grateful for you. If you're watching this later, there's a lot of good material here. We have a lot of stuff on our YouTube site and in everything that we do from emtreview.com. lc-ready.com. We have a lot of stuff here for you. Our job is to help you pass the National Registry and go out and thrive and succeed as an EMT, AEMT, or a paramedic. All right, take the National Registry tomorrow. That's a good time to go through some nooks and crannies for this. So my name is Dan Limmer from Limmer Education. I'm thrilled that you spent this last hour or so with me. I have a very good time doing this. In 2 weeks, we're doing the Jeopardy Tournament of Champions. I'm going to take some of the more challenging questions and put those in, and I hope to see you there. Come back and see me again soon. Y'all take care. All right, a lot of people taking their National Registry, and thank you for the great comments about the stuff that we do. It really is important. I've been in EMS for more than 40 years. If you could have the experiences that I've had, it's our job really to get you there. More than anything else is to go out and do good things for people. All right, if you're taking your test, please let us know how you're doing. Y'all take good care.